Secretary?
We'll start, sir.
Yes.
Yeah, very good evening to everyone. As we had promised earlier in our HODs meeting that we are going to have an interactive session with Vice Chancellor of Rajiv Gandhi University and member of National Medical Commission. So for this meeting, I welcome Dr. BN Gangadhar, Director from National Medical Council, and Dr. MK Ramesh, Vice Chancellor of Rajiv Gandhi University. I also welcome all the heads of the Department of General Surgery from Karnataka State Medical Colleges, and also welcome all the heads of the DNB institutes of Karnataka and all the EC members, and also welcome our immediate national president, Dr. Siddesh sir. And this session will be moderated by our chairman, Dr. H.V. Shivaram sir. I request Chairman sir to continue. Thank you.
Thank you, Dr. Chandrasekhar. It is very, very heartwarming and also our proud moment that both the luminaries have joined us to discuss the issues which are faced by the head of the departments of surgery in various medical colleges and institutions. I'm very thankful to Dr. BN Gangadhar and Dr. MK Ramesh, our own good friend, and also his guidance has helped so many people in this state. He is also an NMC member. That way, I think both of them will help us in solving a lot of issues. It was my promise in the HOD meeting, along with KSCASI, that will bring all of you in one platform so that whatever issues, difficulties are there, we can discuss and then sort it out. With these few words, may I request Dr. Ramesh, Vice Chancellor, to say a few words, and afterwards we'll take a tour.
Good evening, Shivaram. Thank you.
Voice is very good now.
Yeah, I shifted to another computer.
Okay, okay.
So I would like to introduce Dr. Gangadhar first. I think you must have introduced yourself, but he was the director of NIMHANS earlier. Now he is the chairman, Medical Assessment Rating Board of NMC. And sir, actually, Dr. Shivaram is the president of Karnataka State Chapter of ASI, and he is basically a general surgeon as well as a gastrosurgeon. And Chandrasekhar is a secretary. He is in Mysore. He is also a surgeon. And Hepsur is in KIMS Hubli. And Siddesh is the president All India Surgeons Association of India. And basically they wanted to, he said that actually all the HODs of surgery would interact with us to clear certain issues which is concerning to the teaching faculty. And that's why we are meeting here, sir. On behalf of ASI, because basically I'm also a surgeon, I would like to invite you to this meeting. And
I have to, before we start, I'm perhaps not here to solve the issues, but I'm going to patiently listen to the issues. And I'm going to see what are the ways in which we can find solutions. But if I'm here as a participant, I represent the Medical Assessment Board as a president. So that is one of the many of the presidents who are there in NMC. So the commission itself is being head by another professor who is also incidentally a surgical specialty person, as you all know. So perhaps these points what we discussed today, I can share with him, and he will be in the same frame of mind to accept these concerns. How to bring solutions is a next question.
Right.
So,
right.
With that
Thank you very
caution,
much.
maybe I should go ahead.
basically what I feel is they require clarifications on certain issues. Maybe certain things they would like to put forth as the suggestions.
Yeah, excellent. I can listen to the suggestions.
Yeah.
See,
Right.
whatever are the clarifications, if I have the answers, I will definitely share.
Right. Sir, to begin with, Dr. Gangadhar, what exactly is medical assessment and rating boards in the National Medical Council?
Medical Assessment and Rating Board, what is expected from us is to give permission to establish colleges, institutions, courses, whether undergraduate or postgraduate courses.
Right.
Now, in the process, we have no great brain to apply because we are the building contractors, whereas the architect is somebody else. One of the architects was, but is now in this panel here, Dr. Ramesh, for the postgraduate studies. We have another person representing him, Dr. Oza. Another architect is the president of the undergraduate board. There's Dr. Vanikar. So they decide what is the way in which a UG institution, UG course, PG course should be permitted to start.
Right.
So
right.
that permission is a role that we have to do. And for that purpose, we will do many methods of assessment. We are, of course, formulating new guidelines, new regulations for assessments, etc., etc. So the format is provided by two boards, and we call the applications, see whether those applications match that format, and then we let them start their college or a concerned course, whichever is appropriate. This is number one. This is number one. There are situations where we have to annually monitor whether the new college is performing well when it comes to undergraduate studies until it reaches the final year, wherein again the architect will come. Like typically it will happen when you are building a house. The contractor will go and see whether those masons are working all right every week, whether the door is put all right, the brick is put all right. The architect will perhaps come once in periodically, once in 1 month, 2 months, 3 months, and see whether everything has been perfectly made or not. So the undergraduate board or a postgraduate board come when the batch we have allowed to be admitted reaches final year, when they will assess whether all that was supposed to have been given to the student has been given or not. And if it is given, then they will say, okay, you can continue. That's called as recognition. If they don't, then the college will have to stop admissions, fill up all the deficiencies, and seek admissions for the next year, correcting all that if they are corrected. Corrected or not, again, it will be checked by the undergraduate or postgraduate medical education boards to help them check that. Again, we send people to go to the field, examine the colleges, and take on record whether everything is fine or not. Provide that findings to these two boards, who will in turn take a decision to say yes or no to the given college. So, in other words, it's quite a bit of manual labor. And at the same time, manual labor done by technical people is expected to be done a little more accurately and professionally than otherwise. Number one. Number two, we also are expected to do a rating of the college. Whether we do it or we get somebody else to do it, but we are the architects of the rating procedure. We haven't been able to start that for some reason or other. Hopefully, very shortly, we're going to start that. Of course, rating parameters can go on getting added year after year after year, as and when we are able to collect this data as accurately, objectively as possible. So, rating allows a college to be chosen or not chosen by a bright candidate. And it also allows a college, I am ranked number one, I can possibly give charge 5% more fees than the other colleges. So this is a potential benefit to the college if they do a good job. Although that we have not yet really, what we call as converted into a currency, monetized the ratings at this point of time. Although this is one potential that we expect it to be exploited for. And the students will benefit from the rating so that they can make a very informed choice which college to go. Even though I get a college for my rank in my own town, and that college might have been ranked very low, I may decide, look, the trouble I take to stay in a hostel somewhere outside is better so that I can choose a better college. So this informed decision by the parents and the student can happen if we give the rating. And last point is colleges might not be able to follow all the compliances. They will be found non-compliant to some things, one or more things. When such non-compliance is detected, we'll have to find out why it is, listen to them, and if our listening to them, so-called hearings, we're not satisfied, and that we realize that this non-compliance was not something that was just can be ignored and that has to be pulled up. Many ways of putting a penalty is also possible from our board. It could be as small a thing as warning to closure of the given college for a given batch. We can have a gamut of punishments or penalties which we can invoke, hoping that colleges are all as gentlemanly and are not going to enter into this arrangement. I believe colleges, whatever may be the aspirations of the colleges, that's perhaps the only means by which we are getting doctors to our community, government or private colleges. So we have to see them as a partner with our system of building human resource in medical education. And so we keep moving. So in other words, we do an assessment and we also do ratings. Assessment for the purposes of permitting the college, recognizing the college, or for the purposes of rating the college. So by and large, assessment and rating means done for the purposes of rating. And steps, several hearings, several compliances, non-compliances, objective, some objective, it goes on and on and on. So assessment and rating would usually refer to the rating purposes, whereas assessments alone mean assessment for establishing or other reasons. So this is what is the duty of the.
Thank you, sir. Thank you. Thank you for all this detailed explanation, sir. So let us go on to the questions raised by the HODs and professors. I had asked them to send the questions to me so that I can ask the RGUHS or NMC appropriately, they can answer. So Dr. Preeti SP from JSS Medical College, she's asking, when Aadhaar biometric attendance is in, why headcount again in the colleges?
Yeah, not all colleges have been able to do the Aadhaar biometric for all people. If Aadhaar biometric is done by every college, we will not, of course, do the headcount. At this point of time, the people who have been trained continue to do what is there in the manual. Before we remove that, we have to be doubly sure that all colleges have implemented this and all colleges are marking the biometric attendance.
Right. So once it is done, it will be removed.
Yeah, we will probably have to modify our procedure.
Correct. Correct. This is one question from many of the HODs. When, because of NMC inspection, they can't take leave, can't go to conferences, and can't leave station throughout the year. And in the name of NMC inspection, private institutions are denying legitimate leave to the staff, professors, and HODs, and everybody, saying that the inspection can occur anytime, don't leave the station. So the same question is asked by Dr. Hanmantaya, Dr. Gurushantappa, and others also, sir.
So the inspection is 24/7, 365. So that is between the college and the people.
So here I would like to add one thing. See, NMC specifies 4 circumstances where they can take the leave. One is university activities, pregnancy, and NMC activities like this. But what is happening here is the NMC doesn't tell the colleges not to give the leave. But the colleges are adopting the, what do you call that? What do you call-
Harassment principle.
Yeah, we don't say they are what I can call safe method. So they tell the teachers not to go anywhere. It's not good actually. In fact, we also sensitize. We try to sensitize the assessors to be sensitive and humane when going through these conditions. But unfortunately, even if we tell, especially the private colleges, don't give leave.
Can I make a point?
Sir,
This is something that I am requesting all the medical colleges to follow. There is something called as a minimum standards requirement. And the very word says minimum. When I say minimum, that means below that it cannot come. It is like minimum distance you have to jump to be able to cross a gutter. So if it is 2 inches less also, you will fall into the gutter. So minimum definition is that. But still, but yet, NMC gives a margin of 5%, 10%, couple of places, different percentages are given. This is below the minimum. And to be able to retain minimum, given the issues such as people have to fall sick, have to go to medical leave, maternity leave, transfer, conferences, etc., keeping all in mind, it's common sense to expect a few more to be employed. Minimum is what is the minimum that should be available at any time. Minimum does not mean minimum people whom you have employed. So the assessors would obviously see whether the minimum fellows are there or not. And of course, keeping in mind all these pressures, circumstances, on that day a person develops fever, on that day somebody has a fall, on that day he has his wife or mother, somebody having to be taken to some hospital. On that day, he has got the wedding of his son or father, son or daughter. So given that situations, we believe that 5% margin can be given. And other people who, it can't be that other people are all on leave on that day. It happens that whoever is absent has a legitimate reason, and the percentage of less is 10, 12, 13, 15%. Then the question comes. So this is something that I think in the interest of the students, when I say minimum, this minimum is required to train them. To be able to preserve that minimum, how much is the extra you have to keep? That is a decision that each college has to take.
This is one aspect, sure. The aspect is basically I ascribe it to the dishonesty amongst our doctors and the institutions. Basically, all these things happen because of the ghost faculty. Since we know that colleges employ ghost faculties and many of our colleagues go as ghost faculty to many institutions. So because of these things, assessors are extra careful in extra careful in accepting the legitimacy of the teachers. Basically, it's a chicken egg story. That's all. Ultimately.
right.
Actually, if you see, sir, if you see, I have gone to many countries. I have seen the teachers available, etc., etc. Per student, the numbers of teachers that NMC has prescribed is very, very small. It's very, very small compared to many other countries. So, and also we ourselves have called it as minimum. So when we say minimum, that minimum has to be ensured. That is the agenda.
Right, sir. So the next question from Dr. Hanumantaya is that since daycare surgeries are more now, will NMC reduce the bed strength?
I concede this argument. But the point is surgeries are fewer. But the students have to learn from the patients. I agree with you as a surgeon, sir. You will see the patient in the OPD and ask them to come for surgery on day X. But for a student, how will he learn? He has to learn from the patients who are on the bed, no. So this is a problem. I am aware of this. This is a difficult situation because in the OPD, students will not get so much time to be exposed to patients. Although there are patients, nor will you get time to teach them, nor will they get time to see so many patients. OPDs are generally quite overcrowded, and obviously there's no single separate room for students to put the patient on a cot and examine, take history, etc., etc. This is a serious limitation, and the students learn quite a bit from inpatients who are on the beds. So this beds requirement for purposes of education is required. So I'm afraid whoever is doing a teaching a medical college hospital, this margin has to be accommodated, or some method of training people, even if those people are outpatient surgery fellows. How do you do that is a methodology we need to evolve. But I know there is a difficulty in keeping people who have to go for a surgery. They will also prefer to come on the day and get surgery done and go away. But this is a student training is also equally important. So think about it.
Right. See, according to NMC criteria, 3 units per 100 students admission, 4 units for 150 students admission. Then why there are 8 units for 250 students admission? How to run 8 units per week? 6
No
units
answer.
per
I have
week
no
is
answer.
I will elaborate on this. In fact, when we went to NMC at that time, Dr. Gangadhar was still in Bangalore. This issue came, I raised this issue. In fact, we wanted to abolish that 8 units for 250 students. What happened, the deliberations went on for 2 days. Due to some permutation combinations and some statistics, it couldn't be reduced. And even UG board is thinking about it will be abolished. Shortly, it will be removed actually. Because we know it's not possible to have 8 units. The idea, main thing is that they should have the staff as much as for 8 units to train 250 students.
Right, right. So finally, this will be taken.
Yeah.
The NMC orders to pay.
Sir, one more thing. You didn't even ask why 3 units per 100 students. You only asked me a question, why 8 units per 250.
This
So
is
that why is applicable to everything.
okay.
Go on.
NMC orders to pay interns and PGs in private medical colleges as per state government pay. Why no such order from NMC for private college teachers and faculties?
Basically, shall I answer this, sir?
Yes.
Go ahead.
Basically, this aspect also, if you remember, I has raised this, but our chairman was of the opinion that NMC has no business to deal with the pay structure of the teachers. And this was
I will tell you, it's another issue here. There are many conditions which government salaries prescribe versus government stipend. When I say government stipend is over. There is nothing called as HRA, there is nothing called as XYZ allowances, nothing called as DA, nothing gets added. It's a consolidated amount they're going to be getting. Right. The pay structures across states are different, across colleges are different. There are many other perks that come along with the whole thing. For many of those things, the private colleges may not have the accommodation.
So basically, what we want is, I will interfere here. Like AICTE, they have got a common pay structure for diploma holders as well for engineering college. That's what our medical colleagues are asking. And in fact, I believe that they have a genuine demand. Actually, in fact, NMC should take proactive role in formulating scale for the medical teachers.
Yeah, medical teachers management is a totally state administration agenda, sir. The point is each state will have a different pay scale and so on and so forth. So in each state, there are so many things such as central government and state government thing. Service things are different. In state government, the service standards are different vis-a-vis central government. So there are many issues. They will not get promotion to associate professor until the vacancy arises. Whereas in private medical colleges, the moment he gets 3 years, they want to make him associate professor so that they will get a PG seat. So these are all, we know what are all the confounds that are operating. While this is a very good, I am a teacher. I believe teachers should be given full justice, but I don't know whether it is the NMC which is the medium for doing this justice.
So
to
what I'm telling is, like All India Institute of Technical Education, actually, they have a AICT scale. It's like which all the college can adopt. Similarly, NMC is parallel to AICTA. So NMC also has a salary structure can be formulated. We can advise the medical college to adopt it. Maybe in the coming days.
Yes, a good. I'm 100% for it, but whether this is a domain of NMC in terms of legitimacy has to be seen.
Okay,
Right now, the Act doesn't specify these issues.
Yeah.
Right, sir. So another request that NMC can advise private medical colleges to give financial help and leave for updating knowledge by attending CME, conferences, etc. So advisory role for the NMC for the private institutions and medical colleges possible, sir?
No, why private medical colleges? Why not government medical colleges?
All colleges, yes.
Why? So this is a different issue altogether. This is a totally different issue altogether. Right or wrong, whether they should get some additional financial help or not is not a discussion at this point of time. There can be several such benefits that we may want to provide to the college teachers and other people. So to keep it out, government has already said there are many research projects, research funding sources. You can apply and you can avail those research sources, as part of which you can travel, you can do, buy some things, maybe computer, whatever it is. So the competitive spirit will let you acquire many more resources than necessarily government unilaterally giving it, or a private medical college administration giving it unilaterally.
Right. So there are avenues to go for.
Yeah, there are several avenues, sir, research programs. If there are more research applications are coming, more competitive applications are coming, I'm sure the research funding agencies will augment their, right now, there are not many applications at all. And if the applications come, applications are not of the best standard.
Right, right. This was actually, I think, answered by you, that last question, that NMC should announce calendar of events for assessment of private colleges. Surprise inspection can be done anytime after that. Now, private colleges are not giving leave to staff because surprise inspection assessment can be.
I told you, no, that can happen, since surprise can happen any time. So
Correct.
there is no big deal. There is nothing at all. Nothing at all. So this concept has already been addressed earlier.
Right. Dr. Satish Kumar, HOD of Ambedkar Medical College, he's asking the district residency program. Now in Bangalore, PGs are posted in Namma Clinic of Bangalore. It is better if PGs are posted in district hospital and not in Namma clinics.
I will answer this. So basically, this district residency program,
right,
for the postgraduates in the 3rd, 4th, and 5th semester, the idea is to post them into the district health system, not only district hospital, district health system, district and taluka hospitals. The idea is, by implementing this, that bond system is there. That bond system will be abolished. Basically, central government was of the view that actually rural areas they're lacking doctors. We give the suggestion that once the DRP is introduced, that bond system need not be required, because throughout the year the doctors can be provided. In fact, there is a provision for some states to send their PG to other states also. For example, not many medical colleges, there is South India, many medical colleges, there they can go. But they being posted to Namma Clinic of Bangalore is totally wrong. It's a political decision. I think colleges have to resist. NMC, I don't think NMC will have any role in this. Maybe the colleges complain to the NMC, NMC may take some action. But this one, I think colleges should refuse first. What do you say, sir, Gangadhar?
No, of course, it has to serve two purposes, district residency program. One, to augment health resource persons at impoverished district areas. The hospitals are very impoverished, the crowd is very heavy. This is one component. Second component is they will learn to handle primary care conditions which come to a hospital in a peripheral area. Number clinics are OPD clinics that may not really completely serve the purpose as what we are talking. So the district hospitals will receive patients which are perhaps at the secondary or the primary level care situation. Enough complications would be there, and how would they learn to handle with resources which are not as big as they would have in their own medical college hospital. So this training of managing at the primary secondary care level with whatever skills that they have, and augment the human resource at that level. Two purposes have to be served. So this Namma clinic may be perhaps not be the best for that purpose.
Right, right. Thank you, sir. Thank you.
Thank you, sir.
Dr. Jyoti SK from Gadag. What are the criteria for internal?
I will not know this, sir. Right now I don't have a knowledge on the criteria. Right now, immediately I don't have.
This I will tell, sir.
Okay,
So,
Ramesh.
To become an internal examiner, he should have a 5 + 3 years of experience. 5 years as assistant professor, plus he should have guided one PG. And the PG should have finished his examination. So totally it will be technically 8 years to become an internal examiner. 8 years post MS teaching experience.
Right, right. I think Jyoti will be satisfied with that answer. Dr. K. Lakshman, senior surgeon from Bangalore Sagar Hospital. Regarding RGUHS, can you activate Helinet quickly and facilitate its use by KSCASI members? Of course, the membership fees will be paid by the KSCASI members if there are any fees for the Helinet activity.
Yeah, this can be done. In fact, because of the COVID and the last 1.5 years, it was inactive. Now it's in the final stages. And we are totally reforming it. Earlier, only journals were given. Now I have taken a decision to give the textbooks also. All MBBS textbooks as well as reference books for undergraduates as well as postgraduates. So along with that, all the journals. I think maybe after the elections, another 1 month or 1.5 months, it will be active. And giving to the KSCASI member, definitely I will explore. It is possible, should not be impossible.
Right, right. Thank you very much, Dr. Ramesh. RGUHS can rope in KSCASI, our association, and implement uniform format of conducting journal club and morbidity mortality meetings across all affiliated medical colleges and DNB institutions in Karnataka. This is a suggestion from Dr. Lakshman.
It's a very good suggestion. In fact, I'll be glad if you can come forward and give the format. You'll definitely implement it.
Right, right.
It's a good suggestion.
Yeah, this once you do the uniform thing, all students also become familiar with that.
I think it to all the institutions.
Correct, correct.
We'll do it.
Now there is no uniformity. Students are confused. So I think this is definitely implementable.
Lakshman can do it.
In touch with you and get it done. Thank you very much. Dr. Vijay Lakshmi, HOD of Atal Bihari Vajpayee Medical College and Research Institute. RS4 CBME 2019 batch of UGs. Will they have next exam or NEET exam for the PGs?
No, the next exam, as government has announced, will start from this year, right? 23.
23, right.
So the 19 batch will be taking this 23 exam.
Right.
Yeah, but according to original schedule, by this September, it should have been done.
Yeah, there's still time, no? September is still 3 months.
Are you sure that it will come this year, sir? I'm not sure.
That's your judgment, sir. I don't want to comment being an insider.
No. I'm telling you, they just want to know whether they want to.
For whatever may the reason, all efforts are being put to, as you know, The next exam regulations was also on the website. Many people have given comment. It is closed. Any moment the regulations will be rolled out. So I think the efforts are on to start the exam any moment. Some trials, etc., are being made. So I think the 23 December, as was scheduled, if I'm right, should happen. I am not giving any commitment or nor am I saying no to that date. So having announced, I think we should respect the announcement and wait and continue to be prepared for that.
Thank you, sir. The next question is, final exam will be directly next exam, or will they have right to write theory final exam? And
So
if
those details were there in the next exam guideline that was published on the net as a regulation. I am requesting all of you to kindly read that. It is available on the website, but have been withdrawn. But those who have downloaded in many colleges, I believe they have downloaded the draft of the regulation. I am requesting people, although next exam is not something that I am directly supervising at this point of time. So I would perhaps withhold giving any statement on this. This information was available on the website as a public domain information for people to comment before they freeze the entire regulation and announce it in the Gazette. That could happen any moment.
Right, sir. Thank you. Thank you very much for that information. I think this is a suggestion Dr. Vijay Lakshmi is giving. Better to have 6 weeks instead of 2 weeks of clinical postings.
I will share this. I will share this, sir. If somebody can send this on an email to me separately, all these points, although I have not come prepared for facing a interrogation, so I am not able to make notes on these things. If people can send me this pertinent, this question is something that I will definitely flag with my colleagues in the undergraduate board and see what they can do, whether this should be incorporated or the colleges should take a decision. I will take a call.
Sure. Regarding the CBME curriculum, the faculty training is also required. Yeah,
faculty training has already been initiated. Nodal centers, regional centers have all been identified. It will be rolled out as early as possible. And I think they are working on it. I'm sure the UG board president will be here on one of the regional centers visit in the next 48 hours. So I think something is picking up. It will happen.
Right, sir. Thank you very much.
Exact dates of which I may not be able to comment.
Right. Next question is from Dr. Srinivas Pai, head of the Department of
both these points, training required and the postings are the ones. If you can separately send it to me, I will certainly flag it with our colleague, and so that these are initiated.
Sure. So Dr. Srinivas Pai is asking, there is a clause of presenting, publishing by PG students, which puts pressure on the PG and also the teacher. Outcome of this exercise is poor quality publication or presentation. Can you make it optional instead of compulsory?
Maybe Dr. Ramesh could.
I will answer this.
Take a call on this.
See, when I was there, actually, in fact, I had made some changes to it. That the postgraduate medical regulations, somehow after I came in the last moment, it was kept on hold. It may come anytime, I think, maybe another month or 2 months. In that, actually, in fact, we have abolished thesis, a dissertation, because I found that, in my view, most of the time, the theses are copied or not much effort is put. So what that is, the basic idea of thesis is to see that our students get trained in research methodologies. So instead, we had a discussion how to get our students get an experience of research methodology. So that's why we have given the options. Actually, they can present a paper, they can publish a paper, they can undergo certain trainings. Many options have been given in the new regulations. Is going to come.
Right.
But it was put in the draft regulations. Actually, if somebody would have seen it, they can go through it again.
But what else in the PG level the mentor is expected to do, sir? Other than mentoring in some publications, training in clinical work and some procedures, research clinical work, both have to go together, no? Because these PGs will become teachers later on. So some mentoring has to happen for the purposes of research as well. So I'm not very sure whether this should be seen as a pressure. This is an expectation.
True, sir.
Think
Thank
about
you.
it, sir. Think about it.
Yeah, yeah. Dr. Narasimha Swamy is head of the department from Mandya Institute of Medical Colleges. NMC argued overlap of general surgeons with super specialists, like thyroid is done by head and neck surgeons, breast is done by oncosurgeons, there is GI surgeon, oncosurgeon. So the general surgeons are getting less and less patients where there are specialties also in the department, medical colleges and hospitals. So how to teach UGs, PGs if all cases go to super specialists?
So basically, tell sir.
The super specialists, creation of super speciality is the credit goes to surgeons. So you are the parents of the super specialists. So I won't be able to give an answer for this. But I guess some solution has to be found, not just in surgery, it is also true in medicine. A fellow with hypertension and failure goes to cardiology. A fellow with nephritis will go to nephrology. A fellow who has got jaundice will go to hepatology or gastroenterology. A fellow with peptic ulcer disease will end up in medical gastroenterology. It goes on and on and on. It's endless. A fellow who has diabetes, hypothyroidism will end up with endocrinologist. So a general medicine person will have nothing to do. So if that is the argument, I have no answer at this point of time.
Here,
Yes, sir.
if you observe a phenomena,
Hmm.
wherever a super specialty has been opened in a medical college, the medical college standard has gone down. I don't know whether, I think most of you will agree with me. The teaching of undergraduate students has gone down wherever a super specialty has been opened. So, and this overlapping, it's very difficult to distinguish. I think the professional bodies only should give suggestions how to overcome this problem.
Yeah, I think some, although not as a member of the NMC, I have a suggestion to make here. MBBS training now has to move away from super specialty or multi-specialty hospitals to a district hospital or a taluk hospital. And that training has to come there, and then they should proceed to these places. Because once upon a time, district and taluk hospitals were nothing. Today, they are much, much better. And they are as good as perhaps a Victoria hospital 50 years ago or 40 years ago. So if we are all trained in Victoria Hospital to become medical students, the current students can also be trained in some Talaguppa hospital, Taluk, somewhere outside. So I think we need to relook at the way in which we should start the undergraduate training, rather than train them in super specialty corporate like hospitals, where they're obviously not going to get a wide variety of cases.
So Shurma, I have a question to you here. What's your opinion about that overlapping of the surgeries, like thyroid, head and neck, and general surgeons?
Yes, no, our professional body had suggested that instead of having 3 years MS course, you make it itself as a super specialty, 5 years course of MS, wherein the surgeons at the end, when they come out, they will be specialists in whatever field they choose, like hernia or the breast or the thyroid or whatever it is. So you have a MS 3 years course and a MS super specialty course that may solve these problems where competition comes in different specialties.
So you mean to say no MS of 3 years?
Correct. So actually Dr. Pavanendra Lal had promoted this, and he had given a lot of suggestions when he was in the NMC also, that 5 years MS super specialty course. So because now the students who come for MS, they are joining MS only with the interest of becoming super specialties. From the first year, second year only, they start studying for the super specialties. And some of them get super specialty, some of them don't get. At the end, they may not be nowhere, here, neither here, not there.
But there is one drawback here. See, after MBBS, actually, many students may not have any idea about surgical field. Unless he gets into MS, he will not know where his aptitude is there, whether urology or gastro or onco. This one drawback remains in that.
No, I think as a medical fraternity, we need to relook at the way in which their medical curriculum is
Our
framed.
discussion has to be taken place on this.
I think what we have been doing, maybe, although this is off record, I'm not speaking as a member of the National Medical Commission. Whatever we may be doing only cosmetic corrections. I think we need to make a radical change in which the way in which we prepare the human resource. And obviously, we cannot afford 5 + 5, 10 years for a person to become a specialist. It's too long, and I don't think people can afford that long period. At the same time, I'm not saying that you should half-baked person should be manufactured in 3 years or 5 years. I'm not saying that either. But I think we need to relook at the way in which we have curriculumized entire medical human resource preparation.
Right. At this juncture, this is a very important act. May I ask Dr. Siddesh, our immediate past president of Association of Surgeons of India, his views on this? After that, let me ask Dr. Lakshman also. Dr. Siddesh, can you unmute and give your opinion?
Thank you, Chairman Dr. Shivram. Let me congratulate you and the office bearers for organizing this meeting. And I thank Dr. Gangadhar sir for having joined this and spending time with us to exchange and clarifying few views. And it is very heartening to see our own colleague, Dr. MK Ramesh, heading an important university in our state, which is a health university, and he is doing a very good job. Thank you for your inputs. At the outset, for NMC, my observations is I should really compliment the work which has taken place after it has become really NMC from MCI. The role which I have seen as NMC, what they have done is first the undergraduate curriculum, the what is competency-based medical education. It is a really remarkable work which has been done, but I think it is getting shaped up in the right direction. Let me tell my personal questions, you can say, or observations is, has NMC has a role in restricted to only standardizing, inspecting the standards of various colleges, or has it been taken into confidence, or its role has been taken into by the government, health ministry, in deciding on the number of new medical colleges and the number of new each college can have so many students, because this is ultimately deciding in the healthcare scenario of our country going. We see the general opinion among everyone. I don't know what Ramesh has got a take on this, is there is a dilution of our not only basic undergraduate doctor, but also the specialists. By and large, are you following any particular norms in deciding the numbers? I really don't know. And DNB board has a role to play in fixing the salary of the DNB teachers. Why not NMC has a role in fixing that? This is one of the questions which has been asked. I think that is one more role which NMC should be having. I don't know what are these real clarifications, or I may be ignorant on this. And again, on the teacher-student ratio, there has been, I feel personally, indiscriminately, we have doubled the number of postgraduates for each teacher and even gone ahead to do it 3 times. Well, is it rightful? Because the volume of exposure, and now there is a discussion on reducing the number of beds for each unit. So rightfully, we need to think about the role of clinical material available in the period of 3 years, the amount of training and clinical exposure. Ultimately, of course, it's a very good thing that NMC has made it compulsory to have skill labs, especially for surgeons. They need to refine their skills in the given period. So skill labs is going to help in that direction. And again, role of NMC decisioning, permitting the Ayurvedic practitioners in performing these 80 and odd procedures, which have been, I don't know whether NMC has been taken into consideration or their role in making that decision by the government, which we all feel as stakeholders. We are now not only worried about the number of cases which may get diverted. That is not our primary concern. Our primary concern as stakeholders is about the safety of the patients in permitting this. Whether NMC has a role in that, I just would like to know if quickly. And private players, this is my personal interest as a president, which I took up with the National Medical Council. Also, I wrote a letter, and also I took up personally when I met the health minister about private players acting as agents to bring patients onto the consultants. It is totally against the norms of the NMC draft. But I wrote this letter actually in the new NMC draft, which has been put forward. That is one very good exercise which has been done by the NMC. But I don't know where has it reached about that 288-page draft which has circulated among the associations. We did a good exercise constituting a subcommittee. We went through it and submitted our proposals. I don't know where it has gone, where at what stage now that draft is there, and the requirements about the criterion to that is endoscopy. My special personal request has been suggested by Dr. Sopimat also is with especially to Ramesh, make sure that there is an NMC requirement, endoscopy as a part of the armamentarium required for each surgical department. Yeah, what I'm trying to say is it should be under the control of the Department of Surgery, not just a endoscopy department attached to the college, which usually will be under the control of the medical gastro. So there the surgeons cannot get a basic training of upper GI, lower GI, diagnostic endoscopy at least by the end of their career. So these are my small little observation in the small time. Of course, we can go on. I think with respect to super specialties, or I would prefer to call them as subspecialists, the basics procedures should remain with general surgeons. There should be a way, because they are meant to be trained in doing more complex procedures. Like, for example, a head and neck surgeon should not end up doing a thyroidectomy. An oncosurgeon should not end up doing only mastectomies. So those are basic surgical procedures to be lying with the armamentarium or the list of gambit of general surgeons, where they should be spending more time in doing more complex procedures like dissection, head and neck dissection, and things like that. So that is my view. I don't know how we can take forward all this. I'm sure most of these are consensusly acceptable. Thank you very much for asking me to give me my observations, sir.
Thank you, Dr. Siddesh. Any comments from Dr. Gangadhar or Dr. Ramesh?
No, there are one point why so many doctors. I only make a small comment on that. Although these are comments by Professor Shivram, not so much questions to me, but I thought I will flag one issue of numbers of doctors required. Now, we are on par with most other countries in terms of any technology, any requirements, any money or whatever it is. Take, for example, developed countries, the numbers of physicians available are about 3 per 1,000 on an average. There are some places it is 4, some places it is 7, some places it is 3, some places it is 1. Let's say I'll take a very modest number of 3 physicians are available in developed countries. And what WHO once upon a time prescribed is you guys should have at least 1 per 1,000 population. I don't know why they have to say 1 per 1,000 population, whereas the developed countries can have 3 per. So 3 times more. Why they have to let the developed countries have, and we should be satisfied with 1 per 1,000. This is one issue that I have always been bugged with. Even if you take 1 per 1,000, with the great difficulty, we have now reached 1 per 1,000, more or less. Although people may talk, if you add the AYUSH doctors, which already some concern was expressed, why should AYUSH doctors be there at all, pose the risk for management of these people, etc., etc. To leave that apart, even if you exclude them, we will barely touch 1 per 1,000 at this point of time. Of course, when more and more doctors are coming out, maybe 5 years down the line, 10 years down the line, we may probably make it 2 doctors per 1,000. Would still be lesser than what the West is enjoying, if you want to call it. So more doctors is a issue which highly relative judgment that we need to make. So right now we are just gearing to have 1 doctor per. So I believe the numbers of doctors we have to produce is one issue which you may or may not have a concern. Second point about the numbers of colleges available, etc., etc. Today, as many as about 12 to 30,000, the numbers vary. Students who are aspiring to become doctors are not able to be accommodated here for training. They are going abroad and get trained with some or other inadequate exposure to clinical material, etc., etc. This 12 to 30,000 years, each year the numbers vary. This year, I believe, as close to about 35,000 people wrote the foreign medical graduate examination. So, which means I expect about 30,000 people to be walking out of this for medical learning elsewhere. So, how are we going to ensure that these people are given the opportunities here? And third, which is something which is very important, which somehow we have not really encashed. If you see all the numbers of beds available, only a proportion has been converted into teaching beds. So, which means we have a great potential for clinical training, providing we capitalize, encash all the teaching, all the inpatient beds for purposes of teaching. So, clinical material is plenty, but we have, for whatever the reason, limited this clinical material to some large hospitals only. There are smaller hospitals, there are smaller district taluk hospitals, some CHCs which are there, which are fewer beds, maybe to 30, 40, 50 beds. Some training and some good training can also be given there. So we have to see how to make training for the purposes of training, all beds available be utilized. And so we should still be able to make a good number of doctors out with a good exposure to clinical services. But the fact remains, what will all these doctors do? Whether or not we want, these doctors are coming out. Some from India and some from outside the country. Whatever they are doing now, they will continue to do later also. So we cannot ration the numbers of people to become doctors. It is an individual's choice to become doctor. And then whether or not I'm going to be unemployed and I employed, or I go abroad, I find something else, I become a politician, I become a IPS officer, I become a IAS person, I do this or that. It's a different question altogether. It is a personal choice of becoming a doctor, whether he continues, he gets an opportunity to practice medicine, etc., etc. It's the society to decide. So we as doctors, can we really ration the numbers of doctors coming out? Is a decision that I think we all need to perhaps talk about. Just as much as we never thought about having multiple super specialties having come, who are now coming into, like you said, head and neck surgery. They're also doing thyroid surgeries and so on and so forth. Should they be doing? So these concerns, I think we also have to keep it awake in terms of the numbers of doctors, how they are trained and how they are exposed, and how to allow some career prospects for them, etc., etc. And whether long queues, long numbers of days of waiting, even in general hospitals, the numbers of days they have to wait for a surgery or for a procedure, in spite of all availability, is still very long. And the numbers of hours they have to wait in terms of a good clinic and good hospital is still very long. So these are the issues. The time of the patient, if you have to respect, then we have to have more doctors. How do we produce more doctors is a different question. Some NMC's thought has been one, There could be other thoughts. If there are wiser thoughts, I think we should include them to make the output of human resource most optimal.
Right. Dr. Ramesh, any?
In this, my views are totally, what do you call that, different. Dr. Gangadhar also knows about this because in the Delhi also in the meetings to the minister directly I used to tell. In fact, I always opposed him. It's a wrong decision to open medical college in all the districts. And in the end, he started agreeing with me. And at that time, the concept of opening medical college, depending on the population, came up 20 to 25 lakhs, one college. See, unfortunately, let me tell you one thing. When we went there, the initial idea, in fact, the idea given by a colleague in Bangalore itself, I don't want to name, that every medical college should have minimum 500 students. And 500 medical colleges should open in over the next 5 years. So all these ideas were given by our profession, our colleagues only. And naturally, the politician lapped it up. And when the college discussion about the opening the colleges came, once we came out, that PS of the minister would come and say, sir, you know, these are all political decisions. Aapko bhi malum hota hai, humko bhi malum hai. See, basically, it comes to that. In fact, I told you before that postgraduate medical regulations, which had, in fact, I stayed 2 days more in Delhi before getting relieved to see that it goes to print. I saw to it that it went to print and came to Bangalore and reported here. But after I came here, the secretary managed to get a call from PM Mount, stalled the PGM report because in that I had drastically reduced the PG and staff student ratio. Now it's 3 to 1. I had drastically reduced it, and I devised a way, whatever the way the colleges manage, they should not be able to take more than 2 students per senior most professor. So all these things are there. And the doctor population, see, the World Health Organization prescribes 1:1,000. But as of now in India, it's 1:824. If you include all other AYUSH and all these things. And the government gives a lot of prominence to AYUSH doctors nowadays. So when that's the case, I ask the government to include them also when calculating the population to the doctor population. And the European countries have more number, I agree, but they also provide the job. In this, we don't have the ecosystem. So like I feel that we should monitor our production like auditors do. In the CA examination, actually results at 8 or 12% or 15%, depending on the need for that year. Here, unfortunately, in India, the professional bodies are not very active. This is the role, this is the aspect where all professional bodies to come forward and negotiate with the government or fight with the government or convince the government. See, once it becomes political, it's very difficult to turn it. That's when the pressure tactics work. Unless we do that, we means the professional bodies do that. Let me tell you, medical profession is what you call that on the way to be doomed. Maybe if not today, at least after another 5 years. It is my firm opinion, actually. It may be controversial. You also know, I said one statement, it came in all the papers, this thing and all this thing. It's always there. But by hiding the things, we don't achieve anything. We have to become vocal. Unless we tell to the government, we tell the politicians, we tell the ministers, nobody else will be able to tell. That's my way.
Thank you for being very honest, Dr. Ramesh. Sir, Gangadhar.
No, this is a hen and egg question, sir. We don't have medical teachers who run medical colleges. If you have to produce medical teachers, you have to have more medical colleges or more PG courses. If you have to have more PG courses, you have to have more teachers, and the more teachers, more. This is an endless question, and we are not able to find a good solution. I agree. There will be some lag period between the time we produce some people and they become teachers, and the period of what we may call as drought of teachers that we are going to be experiencing. This is one component. But it's also true that there are many methods that have been evolved in the last few years as to how to increase the numbers of teachers. I'm sure these have come up time and again, increasing the age of retirement and a few other things. Even as recently as a few months back when a meeting happened, there were some people who said those who are hale and healthy, can they not continue to be teachers as long as they are hale and healthy, 75 years or whatever period it is. So these are all issues that are going on. And in the same way, there is a lack of teachers available, a lack of teachers for subjects, preclinical, etc., etc. 4,500 seats of PG were not filled, and they were all in preclinical subjects. We created PG courses to be trained for people to be able to come as teachers to train. We enjoyed teaching. We enjoyed our MBBS days when people taught us, teachers were available. And today, the same subjects, we don't want to let our own kin to go and train ourselves. So there seems to be some issue within our own mindset. I think we need to change. I agree, there can be some compromise on training or not. This is a relative issue. How much we have to improve entirely is left to us to improve the clinical training to our students.
Just a
If
lad,
we have to strengthen our profession, I think somewhere somebody has to step in, add time, improve training so that the new generation gets trained. After all, it is our profession we have to safeguard. I don't think you should expect only the state or somebody else to safeguard. We have to safeguard our.
I tell you one thing here, Dr. Shivram.
Yes.
The 250 admissions in the colleges, it's a negotiated number, basically. Because earlier the suggestion was to put 500 students for this thing, but the government was insisting for 350 students, and this was a negotiated admission strength.
Yeah, this is something that you people, I think professional bodies should say, for a optimal medical college, the size should not be more than 100 or 150, whatever it is. This is something that I think you should try to take care of. You should talk about.
Right,
There's
right.
one college, Bangalore Medical College, where Dr. Ramesh was the head, and I was also a student once upon a time. We had a good learning when we had 150 students. Now I believe there are 250 students. But keeping all these things in mind, there are many, what we may call as monitoring methods we have tried to bring in. One is Aadhaar-based attendance system. I think there's a lot of value into the whole. There's a lot of value. There's no duplication of doctors. There's no duplication of faculty. And like Dr. Ramesh was saying, faking is not likely to happen. Attendance, if they are marked and they are present and going, it will also be marked. And of course, you can also cynically, we can also say the fellow will come on the motorbike, put his thumb and go back and again come back at 4 o'clock and put the thumb on that. That arguments apart, by and large, that is one way of making the teachers available to the students. The second issue which we have tried to add, although not the best though, is to ensure the hospital information system to be linked to our system so that number of patients who are coming there at least is monitored. Yes, you can also say every day they create some numbers and then send it. So we are now exploring the possibility whether Aadhaar can be added to the hospital identity or some identity card that this person came to the hospital, unless it's an emergency. Although we're not going to mandate such a card is required for getting treatment, but for purpose of registration, at least as many people should be getting it. In fact, EAMS mandates such a card to be available, definitely for admission, elective admissions, and as far as possible for all outpatient registrations and all elective appointments, the Aadhaar card is expected. So I'm sure there could be some method in which patient identity, if it is mandated, to that extent, faking will not happen and the patients will get the exposure to the hospital. So there are many methods in which clinical care and training can be augmented, and it's all in us as teachers to make sure the newer generation is fed properly with the academic knowledge so that they are going to be treating us when we're going to be another 20 years later old people.
Thank you, sir. Continuing the same about teachers, Dr. Savita from Karwar Medical College says there should be some research allowance, I think, which is already there. Teachers' honorarium should be increased, academic conference allowance, and differential salary for different specialties.
Differential salaries for different specialties is something of a nightmare, and I don't think we can we can create a caste system in our profession.
Right. Okay. Next is Dr. Kalaivani, Professor of Saptagiri Medical College. CBME curriculum is haphazard and it should be integrated with the old system.
Yeah, you send this point, madam. I'll share it with our colleagues. They can
Oh.
relook at the whole thing. Definitely, I can.
Yeah, I think second question we already discussed enough. MSc.
It is the same college which has asked for too many teachers also, too many students also. She is in the same college and she can go and talk to her bosses and then tell, why are you taking so many PGs?
Dr. Kalaivani, you have to talk to management.
They cannot
MSc
speak.
with more and few super specialty seats. PGs show no interest in PG course and more interest in preparing for super specialty.
Just as much as the MBBS person is not interested in MBBS education, wants to prepare for the NEET exam.
Regulate salary for teachers.
Point made, sir. Point made. I'll keep this in
Or-
mind. At the appropriate time, I'll definitely flag it.
Sure. Thank you, sir. Dr. Gurushantappa, HOD from KMC Hubli. Number of UG and PG seats increase. Quality is a concern, which we all discussed. NMC guidelines. EdCom method of education has confused everybody.
No, why? I don't know why it is confused. It's been going on for 3 years. Why if we can make a specific comment as to what was the confusion, maybe I can bring it to the attention.
Dr. Gurushantappa, you want to unmute and explain?
Yeah, thank you, Shivram. Sir, good evening, sir.
Namaste, sir. Namaste, sir.
Namaskar, sir. Sir, the confusion is probably not many the teachers are exposed to the different the assessments in EdCom. It is getting streamlined, but not many teachers. One. And second, there are many groups made in a teaching session. For example, if you have 200 students, the group of 50 or 25 students have been made, and each group are supposed to be taught by every teacher. The same subject will be taught for, like, for example, 204 teams who should be teaching. So the number of teachers required is very huge, and number of classrooms required are very huge. So it is getting confused, and many times we will have a teaching program.
So what I suggest, sir, this, can you articulate it in a passage and send it to me as an email or whatever,
sir.
send
Yes,
it
sir.
through your office so that I
Yes.
can see whether our people can look at it more objectively and scientifically.
Definitely, sir. It has got a practical problem. Definitely, I can do this, and I can forward it to our
Yes, sir.
chairman,
Yes,
and
yes,
from
sir.
there it will be forwarded
Yes,
to you, sir.
I
Thank you, sir.
also want you to keep in mind, AdCom is not another additional subject. So we are not
Yes,
going
sir.
to ask you to have additional faculty for AdCom. AdCom is a value addition to whatever training that is going on.
Yes, sir. Yes, sir. But the same topic is divided into many teams, many groups.
Okay.
For
Anyway,
that, many people are required.
Yeah, what is the specific concern? If you can articulate it in a
Yes.
maybe 100 words or 200 words, I'll be able to share it with them. So
Sure,
that we will
sir.
see
Sure.
what is the best way.
Yes, sir. Yes. Yes. Thank you, sir.
Yes, sir. Thank you, sir.
Sir, next is examiners have to give explanation for failing candidates. Hence, everyone is giving 100% results. Quality of exam has suffered and the really bright students are affected most. Dr. Ramesh?
Yeah. See, unfortunately, the court has interfering regularly in the examination system. And in fact, the most of the cases, I mean, there is some lapses in the part of the examiners also. That's why if we have removed that form where they had to give the reason for the failed candidates. Last week, I had removed that format.
Okay.
That's been removed now. So no need to give any explanation for failed candidates now. So earlier the court used to say they have to mention, they were not mentioned. So they used to give the judgment answer that way or this way. That the problem won't be existing henceforth.
Right, great. How UG/PG examiners are selected by RGUHS? Any guidelines?
We have got Board of Studies PG as well as Board of Studies PG. for clinical, preclinical, and paraclinical separate boards headed by the board of chairman and with 17 members. And above this, one dean will be there. So they will unitedly make the list panel.
Right. Is there any scope for malpractice, or is there any, if there is scope, how it is prevented or plugged?
See, we should remember one thing, thieves are always intelligent than us. So we try to plug, and in fact, I think actually more than 95% we have plugged. Other 5% if it's happening, I don't know. If somebody brings it to my notice, we'll try to plug that also. But I feel not 95%, 100% is plugged. Malpractices may happen at the local level, where copying, such things actually. That also we try to plug through the web streaming. And actually most of the medical colleges do not indulge in this. I can only name around 4 to 5 medical colleges in Karnataka which are known for copying, that we try to monitor. Ultimately, yes, we should be honest, that's all. The colleges should have the responsibility.
Right, right. So what you are telling is the UGPG examiners are selected by the
Board.
specialty board, and there are guidelines and they are followed, and there is no scope for any malpractice in that. Thank you very much. People who are wondering what is ATCOM, it is attitude, learning attitudes, ethics, and communication. ATCOM, okay. Dr. Shivakumar Rajeshwar from Gulbarga.
Before Dr. Shivkumar comes in, sir, on the chat box, there are very interesting comments that have been placed.
Yeah, I'll come.
It may be a good idea before you close the whole show, collect the chat box into your thing, organize the questions and send it back to us, comments or whatever it is. It will help our future work as well.
Sure, we'll send it, sir. Arrange, train the trainers program, train the teachers program in view of change of CBME method of teaching. I think Dr. Gangadhar already.
Yeah, it is being planned, sir. It is being planned that I think it will be rolled out any moment. It's already initiated. The whole process has been initiated.
Right. I think Dr. Ramesh already told. Please legally stand by examiners appointed by you. Provide strong legal support. Surrendering to courts demoralizes bright and budding medical teachers.
No, definitely we don't surrender to the court. In fact, whenever I am in charge, I've always stood by the examiners. In fact, I have provided the services of senior counsels also. And to tell you, in this year, we appointed the senior counsel, and most of the cases we have won for the first time. Almost all the cases we have won.
Right.
We are with the examiners.
Very good news. Discourage students going to court and discipline the students.
It's democracy.
Democracy. Anybody can go to court.
Now it looks like it's earlier it was very difficult to pass. Now it looks like it's very difficult to fail.
Right. I will come back to Kalaivani in a minute. Dr. Bhagavan from Mangalore. Paper 2 of MS Surgery, Operative Surgery, New Curriculum. It is very vague. Old curriculum had head and neck, endocrine, thoracic, breast, like that. Now it says only operative surgery.
Actually, here the NMC does the syllabus revision. At that time, the committee would be formed. Actually, surgeons only would have put this. It has to be referred to the committee again.
Right. Maybe Dr. Bhagavan can write to NMC or write to us, we'll forward it. Paper 3, tropical surgery. Again, it's very vague. Older one had told gastroenterology, urology, like that.
Yeah, the same answer. The professionals have adopted that. They only have to revise again.
Post MS, post MCH, doing the same surgery, different remuneration. Why?
It's market.
What
market
is correct? It's a market driven. What is medico-legal implication? General surgeon doing carcinoma breast versus oncosurgeon doing carcinoma breast.
No implications. Both are qualified.
Both are qualified. Dr. Sopimat's question already, Dr.
Yeah, it's a good suggestion.
Yeah. Dr. Siddesh has already raised. Both diagnostic and therapeutic should be in PG curriculum and students should be taught. So any views, Dr. Ramesh?
No,
First
it
of
should
all,
be,
the teachers should be knowing.
it should be included. And from the RGUHS, definitely I will include. And NMC also definitely I will recommend there.
Right.
Here, sorry, it was there in the curriculum earlier. I don't know how it was missed out in the last couple of years. I don't see that as a part of the curriculum, and also minimum. It was there in the part of the schedule for training. How many endoscopies, diagnostic endoscopy, colonoscopy to be done under supervision, something like that was there. It has got missed out.
What happened, Dr. Shivram, actually, so
Right.
many people have a different ideas. For example, if I remember, many of our colleagues used to tell this endoscopy is post-MS. We have many colleagues who are of that opinion. So in that board, if such people are more, automatically they are omitted it actually. It's not right.
Right. It's some of
Unfortunate,
our own
unfortunate.
colleagues' fault.
Yeah.
Dr. Kalaivani, please unmute and speak.
Sir, thank you for the opportunity, sir. This is to both the NMC members. So the CBME curriculum, what we have as of now, actually has cut down a lot of portions. The number of hours which we used to teach for one particular subject has actually reduced, and it has become split into questions, which has not included the entire portions. That is creating a lot of confusion for the students to understand. So what I am doing is I'm somehow managing to take some extra classes and I'm finishing the portions. So there should be some kind of change in this, sir, one thing. And all that we could have done is the integration. The integration part, what you have introduced is excellent, because
I heard that, I saw that slide, madam. I think you should articulate this right now. As it is with CBME itself, people are finding the numbers of staff are less. And if earlier version was doing more classes to teach the same subject, now it seems to be a contradiction of what we're talking.
Definitely, sir, it can be done, but it is being split, sir, unnecessarily split. So that is why the number of hours looking is more and the portions have actually reduced.
Maybe
but the same thing is being split. Yes, sir. The old system, what we had is very good. All that we could have done now is only to integrate. Like if thyroid, if I am teaching in surgery, medicine also can teach that, and maybe other subjects. That way, if we integrate itself is more than enough, sir. And these kind of splitting the question for the topic.
Good point.
Yes, sir. It is diluted, sir.
Yeah, maybe if you can articulate it in some form of a text, I'll be grateful.
Surely,
madam.
surely, sir. Surely, sir. The second important thing is, I'll do it, sir. I'll do it, sir. The second important thing is, like how we're all asking for save the tigers, we have to say save the MS doctors and MD medicine professors, because sir, we are needed to teach
now
the
you have to save MD
undergraduates.
pediatrics also.
Yes, sir, please.
Pediatric neurology, pediatric gastroenterology,
Yes,
pediatric orthopedics, and so on. Pediatric surgery is already there. I'm sure
Sir,
there are
we have to, sir.
To tell you,
We have to, sir. Yes, sir.
one point here, when I was the president PGMEB, I have abolished 17 super specialties.
Thank you, sir. Because MBBS students have to teach the patient as a whole, sir. And even for MS, we have to teach the patient as a whole. Now it has become organ, only organ. And because of which the patient is not being treated as a whole.
Whole is full of holes.
Yes, sir.
Thank
so
you.
we have to get back the sanctity, sir.
Yeah,
thank you, sir. Thank you.
Dr. Lakshman, you want to comment anything you had put about the private?
Very nice meeting, and congratulations on this. And thank you for active participation. I'll keep it short. A large part of the healthcare delivery in this country is now in private sector. And it's a huge resource of teaching material. With the safeguards, I'm not saying it should be a free for all, but with proper safeguards, NMC can look at this and harness this huge pool where private practitioners can be recruited in the teaching process. Dr. DK Srinivas, 25 years ago, told me that you don't have to be a teacher. You don't have to be in a medical college to be a teacher. I took him seriously and taken active part in academic activities. And I know of many, many more private practitioner colleagues who have a similar mindset. So it's a sincere request. It need not even be for a remuneration. There may be many, many private people who are making a good living with their private practice, who would be agreeable and willing to provide a part of their time for training youngsters, and that pool should be harnessed. Thank you.
Thank you, Dr. Lakshman. Taking
And
some
Dr.
of
Lakshman
the-
Dr. Lakshman may give various models of how private practitioners can be teachers. I can give a list of things, but you can also give me one is whether private practitioners would go to that college or would those students come to the private practitioner. Both components have to be looked in, and if it can be welded.
Exactly, sir. I'll do that, sir. I now have situations where students, postgraduate students in medical colleges are requesting guys like us to come and spend time there, which we'll be ready to do. We can also get them across for postings with us, all in a formal and controlled manner. I can understand the abuse, but we can address minimize the abuse part of it, but we can get them across and help them. Thank you.
We can keep this in mind.
Thank you, sir. So many people have asked, can there be time frame for NMC inspections, not able to give any leave for years? I think this
They are not to give leave
leaves.
anytime, or they can give leave at any time.
Right.
Because the inspections can happen 365 days. So one option, there are many options you should suggest whether inspection should be there at all. Give me a viewpoint whether inspection should be done at all. Why can't I trust a college who says that I have 100 patients and I have 20 deliveries, I have 30 surgeries, and I have 20 faculties, and I have one CT scanner? Why can't I trust? Why should I inspect?
Correct. The fault lies.
Why no one has asked me why you should inspect at all?
Correct.
Just as much as saying that give a date for inspection, I could as well say why inspection? Why can't you trust us?
So Dr. Suresh Uchannawar asked a very interesting. Many of our MBBS students are not interested in studying medicine. They are forced to join by parents. Can we have 1 to 2 years of pre-med school after 12th class where the students can definitely assess whether
Very valuable. I saw that. In fact, when I made a comment about you having to store this data of comments, I noted Dr. Uchannavar's comment. It's very important. More often than not, the parent is interested to know that his son is a doctor or a daughter is a doctor. And also because he or she, they themselves could be professors, doctors, practitioners, nursing home people. They want their son or daughter to join them, and so on and so forth. We only blame the politicians that they breed legacy into their children in politics. But don't we also do it? We also do it. So how much we should make it democratically for the will of this kin rather than forcing is an issue. I think it is difficult to debate at this point of time. It is a subjective decision for each one of them.
Actually, when I go for a graduation ceremony, nowadays I tell, earlier second PhD used to be called the turning point. Now I say the graduation turning point. So now opportunities are very high. I tell them, if the aptitude is not there, if you feel that you're not the right person, don't hesitate, quit the course. Go to business, IAS or MBA. I invariably tell in all my graduation day speeches. Because earlier we never had the opportunity. Now a lot of opportunities are there. So if they join, if they don't have the aptitude, it's better to quit at that point than to continue for another 40 years.
Dr. Narayan episode says overall quantity of doctors is increasing, compromising the quality of education, which needs to be addressed. That all of us discuss. Dr. Sadashiva Sopimat, what happens after a few years when we will have surplus of doctors and specialists.
Like dentists and engineers, no?
Has increasing the number of students has brought down the quality of education? Dr. Gurushantappa is lamenting on that. Professional fee is not at all comparable to developed countries, sir. More so with increasing schemes. Dr. Sopimat, you want to make any comments? Please unmute and speak.
Was it for me? Was it for me, Dr. Shivram?
Yes, Dr. Sopimat.
Okay. No, I was just wondering when everybody was mentioning about the number of seats and all. One which, though it is not concerned with the surgery per se, but we see that the family physicians are missing, the allopathic family physicians, because one of the statement made by one of the NMC person or MCA person was that nearly 40,000 plus students take up the post-graduation. So where the integrated care is, comprehensive care is being given by a good family physician, I think that's really missing. I don't know what MC can really look into. I can understand, but can there be pyramids? Is it because we have created a lot of postgraduate seats, or is it the availability of these seats? Can there be some pyramid system? What can be done to restore that?
I agree with you. A good MBBS person should be a good family physician as well. But at the same time, in the recent maybe a couple of decades or so or more, that everyone is eyeing for a PG course, and so much so the media and other people say that where are the PG seats available to people? So many aspirants are there. What the government is doing, what NMC or then MCI is doing. It goes on and on and on. 20 lakh people this year, 22 lakh people wrote the PG undergraduate examination, and we have less than just about a lakh UG seats. That is 20 lakh applying, and we have 1 lakh. 1 out of 20 will get a UG seat. So was the case for PG also a couple of years ago, and slowly things have gotten changed. Every fourth applicant has a chance of getting a PG seat today. So this issue will go on haunting. If you give less, public will haunt us. If you give more, doctors will haunt us. It goes on. I don't know where we can find a good via media, but public health or a family practice scenario has to be strengthened. I also agree with Dr. Sadashivaya on that. I am in agreement.
I think that Sopimat wanted to know about the family medicine.
Family medicine
is
not a good. No. I don't think he said that. I don't think he said that at all.
No, because of the demand, the seats have been increased. So because they are available, everybody wants to. And people are not realizing that there is a family medicine available, which is not strengthened. It's not given stress that it is, of course, because most of the colleges are, they have this super specialties and all that. So if there is a good comprehensive center where it can be really pushed, I think we can create really good family physicians. It itself is a super specialty, I think, should be promoted as a super specialty.
That's what I wanted to ask, answer this question. See, this concept is there in Western countries. In UK, for example, the general GP practice is there. They go for training for 3 years, 6 months in each department. They get trained and practice. But similarly, with that idea, DNB course was started by NBA. And there was a demand for NMC to start that also. But the problem is, for example, to give an example, I used to receive a letter from an ex-military officer that his daughter has done MD family, the DNB family medicine. She's not been absorbed anywhere. What shall we do? The problem here is in UK, there is an ecosystem is there. If somebody has done the GP practice, he'll go in certain area practice. And if the patient from his jurisdiction, if he wants to go to a specialist, he has to get the reference from that GP physician. That ecosystem we don't have here. So unless we create the ecosystem, that family physician concept will not click here. First, we have to create the ecosystem where we can observe. For example, in Bangalore, Namma Clinic or PHCs. If somebody has to go to corporate hospital or consultant, he should mandatorily get a reference from that GP. Then only the family physician concept can be clicked. Otherwise, it doesn't work. Even if we don't have a rule, even the PHCs, they cannot absorb them. They are neither specialists nor GPs.
The government has to change the rules.
Exactly.
Yeah,
Ecosystem
yes,
is to be
yes,
created.
yes.
So why there is no stipend for students in private medical colleges who got seat through government quota? Is that true? Dr. Vijayalakshmi is asking.
No, it's compulsory. So what have it is compulsory. Stipend is mandatory. In some institutions they cheat, but students should protest. Bring it to the notice of the authorities, to the DMA and the secretary in the state.
Right. I think I have covered most of the questions of the HODs who had asked and wanted clarification. If there are any more, they can definitely mail it to me or WhatsApp. And Dr. Gangadhar and Dr. Ramesh are agreed to share their email, and we can send it to them, and they will also take up with the higher ups. That's a very good news to all the surgeons here and also the HODs. I must thank Dr. Gangadhar and Dr. Ramesh for spending so much of time and also giving us so much of insights, information, and what is the future, what can be done, everything. And it was a very, very extensive and very in-depth interaction. And Dr. Gangadhar sir, you joined today. It has given us so much strength, and also we know how NMC works. And Dr. Ramesh is our own person. We can anytime approach him, and we will also trouble you on and off, sir. Definitely all those notes will reach you sometime from Kalaivani, Dr. Lakshman, Dr. Sopimat, Dr. Siddesh, all of them. So whatever best possible, along with our association and with the help of National Medical Council and the RGUHS, how we can help our profession and the future doctors and surgeons will all work together, and I'm sure we'll find some solution. Thank you very much, sir. Thanks a lot.
Thank you,
Thank you,
Shivaram.
sir.
It was,
Anybody wants to have any last comment?
And Dr. Shivaram conducted the program very well. I think on behalf of all of us who heard him, heartiest congratulations, and I deeply appreciate the way you conducted the programs.
Thank you, sir. Thank you, sir.
thank you,
Shivaram,
Shivaram.
I
Pleasure
think this
meeting
should
my
become an
colleague.
annual event. That is my comment, if possible.
You should make me a permanent chairman.
No. It is just a wish. Let us see that future also things continue.
Yeah, next year episode will definitely do it. Let us see. Sure, yeah, it should be, because HODs keep changing.
So many things. New things will come in.
New things will come in. Correct. New
Sir, if
ideas.
Ramesh sir and Gangadhar sir will cooperate, we will we'll surely have it again, sir, next year.
Absolutely. Chairman-elect is speaking. Thank you very much, Dr. Hebsor.
Yes,
Thanks
sir.
a lot, sir. Good night. Thank you very much.
Thank you.
Good night. Good night.
Pleasure meeting you all. Thank you.
Thank you.
Thank you, Dr. Ramesh. Special
Thank you.
thank you.
Thank you. Shivaram.
Thanks all.
Thank
Thanks
you.
all. Thank you. Thank you.
Night.
Thank you. Thank you.
Good night.
Thank you, sir.
Thank
Thank
you.
you, sir. Good night.
Good night. Good night.